Get started. So the patient presentation for this case is a 62-year-old female who presented to clinic for evaluation of gait instability. Her daughter was with her and stated that she had been walking very slow and had trouble initiating her movements. She also noted that her facial expressions had seemed to change, and she seemed to seem flat and unexpressive. She said that these symptoms had been going on for about a year, and they had been progressively worsening over that time. When I talked to the patient, she also reported that her mother had similar symptoms as well. So on physical exam, she had a mild increase in tone of her bilateral upper extremities, the right greater than the left. She had a moderate decrement in both speed and amplitude on finger taps and both opening and closing of her hands bilaterally. There was also retropulsion as well. And overall, her exam had mild Parkinsonism on. So when we look at her CT brain without contrast, so I'll go ahead and play this. So as you can see, there's calcifications involving the bilateral cerebellar hemispheres, the basal ganglia and the thalami, as well as extensive linear striated calcifications involving the white matter of the bilateral cerebral hemispheres. On labs that are pertinent, she had normal calcium, phosphorus, magnesium, alk-phos, calcitonin, PTH, and vitamin D. And so for this patient, she was diagnosed with what we previously called Farr syndrome, but is now more termed as idiopathic and familial basal ganglia calcification. It's a rare inherited or sporadic neurologic disorder with a prevalence of less than 1 in a million. Most commonly, it is autosomal dominant, but it can be autosomal recessive or a sporadic gene mutation. But you do see these calcium deposits, usually symmetric bilateral basal ganglia, thalamus, dentate nucleus, cerebral cortex, cerebellum, and subcortical white matter. Typically, there's a wide range in the literature, but somewhere between 33 to 50% of patients have neurologic symptoms. The rest are asymptomatic. Most cases, when they are symptomatic, present with movement disorders, with Parkinsonism being the most common at 57%, but you can see things such as cerebellar dysfunction, speech difficulties, dementia, and neuropsychiatric symptoms. The calcifications, they generally develop within the vessel wall and the perivascular space and then extend into the neuron. Causative mutations that have been looked at are listed here. And there's also been a link to chromosome gene 14q in certain families. So for these patients, you do need to look for secondary causes. So hypoparathyroidism, pseudohypoparathyroidism, and hyperparathyroidism can all lead to brain calcifications. And treatment of those disorders would be to treat that underlying endocrine issue. Otherwise, for patients with Farr syndrome, it's mainly symptomatic treatment. For patients with Parkinsonism, there is a variable response to Sinemet. Most people don't have a great response, but there were some case reports of patients having a response enough to help them with their daily activities. And that is it. Thank you.
Thank you, Kristin. That was short and sweet and sad too. Beautiful case. All right. Today's, again, CME code is ROV-CUG. I'll put it in the chat again. Grand Rounds today is being presented by our vascular division, and it's again a joint Grand Rounds based around S-nitrosoglutathione. And our guest speaker is Dr. Inderjit Singh, and our own Wayne Feng is going to be involved. Now, we all know Wayne, but Dr. Singh is currently at the Medical University of South Carolina. He got his master's in biochemistry at Punjab University of India, and then made a huge change to Iowa State in Ames, Iowa for his PhD, and then joined my old stomping grounds at the Mass General. Dr. Singh, I looked at the years and we did overlap, but you were in the Shriver Center and I was in the cafeteria. Then you went to Hopkins, so we're like twins separated at birth, where you rose up to associate professor of neurology and then went to Medical University of South Carolina, where he's currently the Sherman Financial Group Endowed Chair in Neuroscience. We're honored to have him and our own Wayne, Dr. Feng, who's was also at the Medical University of South Carolina giving grand rounds today. And Wayne told me that you'll start off, Dr. Singh, so I'll hand it over to you.
Okay, thank you. Will you turn to this music band? How do we go with that?
Dr. Singh, you can email me so I can open from my end. I can add advanced slides for you.
It's sometimes hard to find the share screen button.
It's on the bottom. If
Yeah,
you
it's on the bottom. If you kind of
Okay.
tap anything that looks like Zoom, it'll be on the bottom in green.
It's a green, it's an arrow as well.
Oh, here, this one. This one? Yeah.
There you go. Perfect.
Okay. Just press those one.
It's a terrifying moment, isn't it, to try to, when you can't find the share screen button.
Well, I'd like to thank Dr. O'Brien for a very kind introduction. And also like to thank Dr. Feng for this invitation. And Dr. Feng and me start thinking about this project a couple of years back. Then he moved to North Carolina. So we are trying to reconnect again. So as shown in the first slide, I will be discussing clinical relevance of nitoxide in ischemic stroke. The gist of the talk going to be the nitoxide metabolites. Nitoxide have a very short half-life in the body. One metabolite of nitoxide is very detrimental in any disease condition. Other metabolite of nitoxide is very protective and regulatory activities in normal physiological functions. The slide. Okay, so basically it's a, just for introduction, common disease. There's only one drug approved for a long time for ischemic stroke, TPA, that also had some risk factors in terms of hemorrhage, and also had limitation that it reached very small number of patients. Recently, the approval of mechanical thrombectomy opened the field to test all the neuroprotective drugs. And this, with this in mind, when we start talking how we move forward in this approach. Before I talk about nitoxide, I just want to emphasize that stroke is a very complex disease. Multiple mechanisms participate in the outcome, disease pathology. Just I listed in blue on the bottom, few of them, and on each activity, there are multiple mechanisms that are dysfunctional. So for a drug to be effective in stroke, we need to have a drug which target multiple mechanisms or disease pathology. Unfortunately, for a long time, we were testing on single genes, single proteins, single activities. Outcomes were very limited. Today, we are trying to share with you that by optimizing GSNO, by giving exogenous GSNO, or by optimizing its levels, by inhibiting its breakdown, we can target multiple well, these functions which go wrong in disease pathology. With the result, targeting one disease, one enzyme, we can address multiple pathologies. So basically, just to give an overview, the nitroxide is synthesized by nitroxide synthase. There are 3 different kinds. In neurons, there's a neuronal NOS, there's endothelial NOS, there's inflammatory NOS, and all make nitroxide. In addition to nitroxide, also nitroxide produces superoxide. And superoxide, that drives the function of nitroxide metabolites. That if superoxide is produced in much higher amount in pathology conditions, it immediately gets turned into peroxynitrite. Peroxynitrite makes nitrotyrosine, and that is a pathological event. On the other hand, under physiological conditions, that it reacts with glutathione, makes GSNO. This is the biological carrier of nitroxide in the body, because nitroxide half-life is very little when it's made. And this is the latest signaling, secondary modification signaling pathway in biology, that way by nitrosylation of the proteins, where the nitroxide from GSNO goes to a different protein, molecules or receptors, whatever, and regulates those functions. Okay, that's a nitrosylation, and there's all physiological functions, and now it has been recognized to really regulate hundreds activities. So basically, nitroxide dysfunction in stroke was known for a long time. Just like over here, 2003, somebody said there's a decrease in nitroxide in stroke patients. And so, but nothing happened after that. And we followed that, looked at it, how to regulate the nitroxide loss under these conditions. So we used our own MCAO model, middle cerebral artery occlusion model, in which if we, in a stroke condition, there's a decrease in nitroxide, which is very much same what they see in the patients. And decrease in nitroxide correlates the increase in peroxynitrite. That means the nitroxide, there's a decrease in nitroxide, but there's an increase in peroxynitrite. And that was expected. What we found that if we give GSNO to these animals, we can increase the NO, that's fine, but we can decrease the nitrotyrosine. This pointed to us that some way this GSNO regulates the NOS functions. The NOS function in terms of producing nitroxide or peroxynitrite. So we expanded on that, and just to give you overview again, the NOS produces nitroxide. It can react with glutathione to GSNO. All the physiological functions are regulated by this. On the other hand, if it's under aberrant NOS, which is dysfunctional NOS, which happens in stroke, it becomes into peroxynitrite. You see all these things which we don't want in stroke. That's what happens. So the whole game is how to regulate this balance. Rather than going this way, how we can shift the equilibrium towards this side. So you study the same standard MCAO model, and study the effect of nitoxide. So using GSNO. And under acute disease conditions, we looked at neuronal cell loss, blood-brain barrier, neuroinflammation, and neurodegeneration. Acute phase. In long-term studies, we looked at the angiogenesis, neurotropic factors, improved function recovery, and that's it. So another issue was at that time, about 10 some years back, everybody was people are studying different nitoxide donors. All nitoxide containing molecules don't have the same activity. So it took a while for us to figure out why people have conflicting results. One says beneficial nitoxide, my nitoxide compound, others say my nitoxide compound didn't work out. So we classified the nitoxide compounds which are being studied into 3 groups. One which gives free nitoxide. When it gives to the animals, it releases as a free nitoxide. Other one which gives like compound like SIN1 gives peroxynitrite, means both superoxide as well as nitoxide. There's a third group of compounds which don't release nitoxide to the medium. The advantage of that is that if it's not released into the medium in the body, that it does not react with superoxide to become peroxynitrite, which is deleterious. So it's only transferred from GSNO to the proteins and protein back to the other proteins, so or to back. And this is, we call it transnitrosylation. So if you look at on this figure, and transnitrosylating agents are very protective. If you give free nitoxide donor, not that protective. If you give a donor which gives nitoxide plus superoxide, that's also deleterious. So with the result, we send the paper to nitoxide journal, and we say that all the nitoxide donors are not same. We had to be careful in interpreting the results. So they put us on the cover sheet at that time, send a message, all NO donors are not the same. So that changed the study design of various labs. So basically, I will show you that first, that it's a protective in neuronal injury, in stroke neuronal injury. Earlier event in stroke neuronal injury is dysfunction of calcium homeostasis and dysfunctional NOS activity. Functional NOS does not produce that much superoxide, but aberrant NOS produce a lot of superoxide that leads to a lot of peroxynitrite and cell death. And this NOS is regulated by 2 molecules. One is GSNO, one with these kinases, the phosphorylation. Remember when I showed you one of the first slides where we got this idea from. When we give the GSNO, the levels of nitoxide, peroxynitrite were reduced, nitrotyrosine was reduced in that. So when this becomes dysfunctional NOS under hypoxic conditions, this protein is activated and this phosphorylate. This phosphorylation of this molecule directly correlate with the dysfunctional NOS activity. Where if we give GSNO, that nitrosylate this protein downregulates its function. Also, nitrosylates NOS and converts the aberrant NOS into functional NOS. So this slide shows that within short time, there's an increase in phospho-NOS, serine 1412. This is associated with dysfunctional NOS. When we give GSNO, that phosphorylation is completely reduced. So then to see that, to document that, yes, this enzyme which phosphorylate makes a dysfunctional high peroxinite producing NOS activity, is it functional? So what we use inhibitor of AMPK, yeah, a lot of protection. Then to say that peroxynitrite plays role in this pathology, we use a chelator of peroxynitrite that also provides protection. On the other hand, if we use activator of AMPK, look at there's an increase in FOC volume. When we give GSNO to another group of animals, look at this, great protection. And so that tells that the NOS and NO activity is very important in terms of playing pathological role. So some other people start thinking, yeah, why don't we use just NOS inhibitors? A lot of people start synthesizing specific NOS and NOS inhibitor, eNOS inhibitors, iNOS inhibitors. And yes, you can have some protection, but this molecule gives you much better protection in FOC volume, area, neurological scores. And secondly, we cannot block the NOS, complete NOS activity, because a nitroxide is required for a lot of functions. So in summary, again, in the first step, the neuronal dysfunction, that here you see the NOS activity, it is increased in ischemic conditions. In spite of increase, there's a decrease in nitroxide, which was observed in human studies, because that nitroxide, which was produced more over here by dysfunctional NOS, is converted into peroxynitrite. If we give GSNO, it can be reversed. There's a recovery of it. If you look at nitrotyrosine, immunocytochemistry, you see a humongous amount of nitrotyrosine in ischemic conditions. Okay, but if you go GSNO, there's a big reduction in nitrotyrosine. So that's where GSNO functions to protect the NOS and NOS activity as well as neurons. Then we also looked at blood-brain barrier, the same standard model. In terms, we produce ischemic insult and ischemia reperfusion. Give GSNO, you start seeing, then we injected dye to look at the blood-brain barrier damage. Here you see blue spot. That is the way the dye diffused out because of dysfunction in BBB. And GSNO protected it. If instead of GSNO, we give another NO donor, which produces peroxynitrite, because there's a much more diffusion of this dye. And so GSNO and this NO completely have opposite effects. And this is a quantitation of the dye. This is the edema of the brain. It also, we look at the vascular inflammation. There you look at E-selectin expression, the much more ischemic conditions, GSNO downregulates it. We also looked at the MPP9 expressions, and that is downregulated. So this was that means it protects into the vascular dysfunctions. Just to stay in time, I have not added too many slides. Just say GSO function at the earlier event, there's a small leakage, and through calcium and ROA activity and enos function. If the damage continues, then it moves forward to making actin stress fibers, which pull the cells away. There you see much better hard leakage. And so NOS plays a role in those functions, these activities. So overview again, and saying that nitroxide signaling under physiological conditions by GSNO provides you protection, where peroxynitrite under pathological conditions is deleterious in all the functions. We also looked at a chronic injury, in which chronic injury we looked at neuro expression of neurotropic molecules and also angiogenic proteins. So if GSNO has any effect in those things. This activity, this is regulated by HIF1 alpha through nitrosylation again. And here we've shown that the GSNO protects against the ischemic injury, but if we inhibit the HIF1 alpha, that protection is lost. So they're telling that HIF1 alpha plays a major role in terms of in chronic injury. And we looked at, just like anybody else, all the neurotropic molecules, expressions, and that sort of thing. But it also compared with the exercise versus GSNO, difference between that and the chronic injury. Here, look at the ischemia reperfusion injury, exercise protected it, GSNO protected it. When we look at all the parameters, both were protective, and if we combine them, we found little more activity, more protection. And the outcome of this long-term study in chronic disease, look at the motor function, body swing test, neurological scores, body weight, all are protected by GSNO as compared to ischemic insult. Then also compare that whether, because stroke happens in generally among the senior citizens, we also took 18-month-old animals, compared with them 3-month-old animals with all the behavior studies, beam walk, footfalls, forelimb placing, and all that. Young animals, there's a protection, there's a recovery, function recovery, much quicker than see the function recovery in older animals. Yes, there's a protection, but the rate of recovery was much slower in aged animals as compared to young animals. So just to overview, you have under physiological resting conditions, there's a calcium and NMDA receptors to regulate NOS activity, regulate calpain activities. Under physiological condition, under pathology condition, there's an overload of calcium, which induces NOS activities as well as calpain activities. On the other hand, if you give exogenous GSNO, that controls calpain activity as well as NOS activity to get more physiological activities, survival of these cells. So with this thing, we thought, well, we are really ready for translational studies. We need to look at how it can be studied in stroke models. And Dr. Feng will be talking about some of the summary of some of those studies. Well, at the same time, when we were discussing with Veal, found out that this molecule, although we find a lot of beneficial effects, better than anything ever studied, but it has a difficulty in commercial feasibility. It's less stable, sensitive to light, heat, oxidative environment, short half-life. So that kind of, although it was used in a couple of human studies, but that was the limitations. So then we start looking at alternate approaches, how we can increase. We need GSNO. We were that GSNO is the ideal compound which can target all the pathological events to provide us neuroprotection, neuro repair. She said, well, how we can do it, that how we can achieve this goal. Then alternately we thought, well, why don't we block or decrease the turnover of GSN in the body because there's a biological molecule. Okay, for that we tested inhibitors of enzyme that degrades GSN in the body, GSNO reductase inhibitors. So, and another thing, surprisingly, what we found, that why there's a dysfunction of the GSNO in the body, in the stroke conditions or any other condition. What we find under hypoxic conditions, as well as inflammatory conditions, there's an increased expression of GSNO. So there's increased levels of GSNO reductase, decrease the levels of GSNO, that results in loss of NOS function and more shifted to peroxynitrite. Look at the increase in activity in the stroke model of this enzyme. So with that, we said, why don't we just use this inhibitor, block the activity of GSNO reductase, increase the activity of endogenous GSNO to bring out normal nitrosylation for functional recovery neuroprotection. So here, one of the compounds, the N115, look at the ischemic, which is standard block in this model, this much degree injury. When we studied, added this compound, treated with this compound, we saw lot of protection, humongous protection. When you infarct volume, infarct area, is water content, edema, even the survival under this model, there's about 20% or 15% animal die, and there will be 100% protection, 100% survival rate. So that we can improve, optimize the endogenous GSNO by inhibiting its great increased turnover of GSNO which is because of increased expression of GSNO reductase. And you can look at all the behavior function, neurological functions, body spin test, footfall test, all are improved with this drug treatment. So then we had another GSNO reductase inhibitor to show that, and also study that. And this is called N6022. And it also provided good amount of protection as shown in the infarct volume and neurological score. And here is the blood-brain barrier damage. Under that, there's a lot of diffusion of this dye. That diffusion is reduced by this drug. And there's under ischemic conditions, ischemia reperfusion, there's a good amount of edema. That's also reduced by this drug. And also, like other inhibitors, it's also produced, increase the survival of the animals. Okay. So, and when you look at the behavior studies and also improved the novel in their activity in novel object recognition, as well as slender tests, these are behavior studies in terms of functional outcomes. So that was all right to use inhibitors, and you don't know inhibitors where they go when you give to the animals. Then we had GSNO reductase knockout mice. And this really provides a lot of confidence that this targeting this molecule GSNO reductase is an ideal approach. As you see over here in sham, wild type reductase knockout mice, if you give ischemia reperfusion, you have, as expected, you have a lot of infarct. Look at reductase knockout mice. You don't see any infarct. And infarct volume, neurological scores. This hypoxia didn't do any damage if you deleted the gene, showing that this gene regulates the pathological hypoxia-induced pathological events. Okay. And this drug shows that here, as compared to this one, wild type, it does provide protection. Okay. And here is similar studies. The GSNO reductase knockout given to ischemia reperfusion. Nothing happens. In wild type, look at how much damage it is as compared to this, just deletion bunching. These mice live long life, have some other problems, but not in stroke. And say, if you say that it is nothing happens, maybe there's some issue. You can say, okay, instead of GSNO, which is optimized under these conditions, we give to the same mice, same one, which is peroxynitrite. Look at how much damage is produced. It's just what kind of NO got generated in this mice because GSNO reductase was deleted. And same is true if you look at the blood-brain barrier, okay, sham and IR reductase. Look at in wild type mice how much infiltration is. If you give another NO donor, that damage, that protection is kind of removed. So basically it helps that GSNO reductase somehow regulates multiple disease pathologies associated with hypoxic insult, at least in stroke. So that was studies from our lab. Then this is study from Case Western. And there's only 3 reductase inhibitors known. This is another one. They studied this reductase inhibitor in another model of hypoxia. So they used a cardiac arrest resuscitation model. This is the PMID number of that paper. So just like there was a 15 minutes hypoxia, then resuscitation. If you look at over a survival rate, and there is loss of about, in this model, 60% of the mice. But if you give this drug, it brings back to 80%, 20%. Here's a knockout mice. This is wild type mice as expected, about 70% loss of animals, while this knockout mice has only 20% loss of animals. Great degree of protection. Under this hypoxic conditions, there's also change under neurological scores. Also, induction of the reductase, even in a short time. Look at destruction of the blood-brain barrier. There's a 15 minutes stunning of the heart, and then resuscitation. The brain becomes blue, and this drug, reductase inhibitor, provide great degree of vascular protection. And this is the quantitation. And let's say hypoxia increased activities, increases activity of GSNO reductase. This inhibitor increases the survival higher than wild type, dysfunction of blood-brain barrier, and deletion of gene protects against the hypoxia and blood-brain barrier dysfunctions. So basically, these are the mechanism for neuronal damage and acute injury. These are the mechanisms in chronic injury. Then we had a problem with the translational work. We have identified another drugs which can do the same work under those in acute injury as well as chronic injury. And so just these studies describe the regulation of GSNO reductase is required for functional recovery in stroke. And these inhibitors, especially N602, is not toxic, have been studied in asthma disease and with number of studies, cystic fibrosis, asthma. So it is a pretty good candidate for translational studies. So this is the same, but at the end, I'd like to acknowledge the contribution of the people who made this thing possible. Dr. Mushkan, Dr. Wan, Avtar K. Singh, Tejendra Damu, Feng Kyo, Jasdeep Deensa, Feng. Wayne started working with us couple about 3 years back. With that, I thank the audience. And if you have any question, I'll be happy to address those.
I think we're going to hear from Dr. Feng first.
Okay, Dr. Feng first. Okay, that's one.
Thank you very much. Wayne, are you out there?
Yes, I'm here.
There he is.
Yep. Hold on. Can you guys hear me okay?
Yep. Yep, we see your slides.
All right. So thanks, Dr. Singh, and really talk about the, you know, targeting the and genus and either introduce exogenous and a genus, or you know, using genus reductase inhibitor to boost the endogenous nitric oxide as a, you know, as a potential and a drug therapy for stroke. There's a lot of data suggesting, you know, that can increase enos phosphorylation and also protect endothelial cell in acute phase, and also stimulate the neural repair process, induce angiogenesis in the chronic stroke phase, really, you know, the molecule has both acute neuroprotective effect as well as neural restorative effect. So here I'm just, as Dr. said, we've been working in the last couple of years really to see if we can take it, you know, moving from the basic lab into the translation process, start a human study. So here I'm going to just talk about from a translation perspective. Here's my disclosures. Has, you know, introduced exogenous and GSNO, you know, seems to be feasible, and it has very promising data in the animal study. So we really look at it to see if is this actually and being already, you know, tested in human subject or other disease conditions. So we actually look at it. You know, it's already the GSNO is really it's a compound and doesn't really have running out of pattern. So actually being tested in several studies. It's been tested 3 studies in healthy subject, clear, they can you know, improve the left ventricle kind of cardiac functions, and they also kind of have effect on the platelets aggregations. There are 2 studies with total with 16 patients, and basically test proof of concept study in women with pre-eclampsia. Clear, you know, they can reduce the vessel tone, possible refraction, and also have some small effect with the blood pressure, depends on the dose. And then it's also been tested for a patient with coronary artery disease. 2 very small clinical trials, single centers, one was 24, the other was 13 patients. Again, really, you know, interesting, those study doesn't really have a clear clinical outcome. Majority just really look at and biomarkers. For example, the study by published in Saras in 1998, and they really look at the platelet aggregation activations. They found that really it's inhibited by GSNO, but it's a small study. Maybe it's not a sample size too small to reflect the clinical outcome. So then we also look at it. Is this really also been tested in stroke or patient with a cerebral vascular disease? And we really find that there are indeed, there's a 4th study basically published by the same group, Dr. Hugh Markers, who is a neurologist, also practiced quite a bit with the vascular neurology, and basically did a 4 studies, really studied the patient with a carotid disease, but it's only by one group, you know, basically they look at a patient with symptomatic carotid disease, and they basically infuse with just G-SNO and a molecule. All they really use is use a transcranial Doppler to look at it if they can reduce the active embolization. As you probably know, the active embolization is sort of kind of biomarker for unstable and a plaque. And similarly, they also did a study, and for those patients present with symptomatic carotid disease, more than 70%, and those patients went through angioplasty or stenting, they basically infuse the medicine and before, and they're doing the procedure. Again, they also seem they can reduce the embolization. Interesting, none of those studies, I'm not going to go to all the detail due to the times. None of those studies actually really look at a clinical outcome. My guess is, the study is very small. Most of the study just about less than 30 patients, probably not adequate to see the changes in the clinical outcome. Sometimes reduce carotid embolization doesn't always necessarily lead to the and changes in clinical outcome, because some of those embolization, most of them are harmless. They even you detect, they just they just lost and they disappears. So I actually personally emailed Dr. Hugh and then asked about it, if they actually collect a clinical outcome, but unfortunately I didn't got a response from him. Anyway, we actually worked together, really did a kind of meta-analysis, look at how and the possibility of introduce G-SNO and as a viable approach for stroke and a therapy. So we analyzed data in both preclinical and clinical process. In the preclinical part, majority work was done by Dr. Sen, and of course now some of the data has been replicated by other labs. For this one, and the clinical study, the full study, clear, if you do meta-analysis, clear just show some, and positive response, and for the group and with G-SNO. And then we also use PJOS and the score really analyze the quality of the all studies. The big issue is now in the study, actually, they conceal the allocations. So we can know there's a lot of quite a bias can be introduced to those clinical trials. So we really look at all the study. We find it's mainly done, by a very small group, and just one, for the carotid disease, mainly just by done one group. And if you look at preeclampsia, coronary disease, and they're really very small study, basically just has not been replicated by others. There's a significant dosing issues. Majority dose is actually 1.5 microgram and per kilogram per minute. And we really don't know what is actually the optimal dose and for stroke patient. And they all claim it to be safe. However, you read all the detail, there are few patients actually introduce a G-SNO that does, and a drop of the blood pressure, which can be a big issue if we really translate it to acute stroke therapy. Majority uses surrogate outcome without a really clear clinical outcome. We need to design a much better studies with much larger sample size in order to really to see if really kind of feasible to translate and this molecule. As Dr. Singh also pointed out, the genus and it's not a very stable, and have very short half-life, which can be can be an advantage, but also can be disadvantage in terms of translational. Now, Dr. Singh has two compounds, basically, they are G-SNO reductase inhibitor, really can boost the endogenous nitric oxide, which might be a good way. Or maybe we should be thinking about maybe doing combination of, induce exogenous nitric oxide or boost the endogenous and nitric oxide. So those kind of things we really need to think about it when we really translate the process. What I really see a couple of years ago is really, I think there's an opportunity in neuroprotection and during the acute and stroke phase. As we probably know, the endovascular therapy really revolutionized and for ischemic stroke patient with a larger vessel occlusion. Here I just list, bunch of and landmark study ranging from Mr. Kling to the recent kind of Dawn and diffuser study. They really extend the treatment window beyond 4.5 hours. Now, basically you can treat a certain stroke patient as late as 24 hours, depends on the imaging selection. If you really going through all the studies, and really what you find out is there's very high rate of successful recannulization rate. In the surface prime, literally, success vessel recannulization rates can be achieved 88% of those patients. But if you look at their good outcomes in 90-day, they are relatively low. And there's a mismatch, means that some of the patients, they have a success recannulization, but patient actually didn't getting better at 90 days. So with this, really, got attention from NIH. NIH actually 3 years ago, and actually released IFA, really, and created called a stroke preclinical assessment network called a SPAN. Is a preclinical network to support a translation study for acute protection and prior to endovascular reperfusion therapy in stroke. And right now there are the networks actually already being activated. And Dr. Patrick Linder from Cedars-Sinai is leading the SPAN network. And Dr. Aronofsky from UT Houston, they are testing tocilizumab, which I believe is the immunomodulators. And David Hess from Augusta University actually testing a device I call it remote ischemia preconditioning or post-conditioning. Dr. Raymond Kohler, I'm not sure I say the name correct, actually tested a chemo drug called a Valiparib at MGH. Oops, looks like I'm missing the Hopkins. Don't remember. Oops. They also test another molecules. And University of Iowa, Dr. Lear actually tested uric acid, which is actually which shows promising data for neuroprotection. Laura Sanchon from Yale actually tested MS drug, Flingermod. They're all showing some promising data. Maybe possible can be translated to human study for neuroprotection, can boost acute therapy. I believe Dr. Singh also applies this network, but in the end was not a selector. We try to see find the viable mechanism how we can move the translation process. So a couple of months ago, NIH actually released called a blueprint for a neurotherapeutic network for small molecule. So here we started talking again, and I think the time is really ready to test the so the G-SNO reductase inhibitors to see if they are viable and a molecule for neuroprotection and a neural repair process. So that's all we have. We're going to stop here and answer for questions.
Thank you both. Anyone with a question, either type the question in the chat or just put your name there and we'll come to you. First of all, thank you both very, very much. It was very, very interesting. My comment is at the beginning, I showed a slide from one of our investigators, Danny Laskowitz, and his use of an ApoE peptide mimetic, CN105, for intracranial hemorrhage. He also believes it has an effect in ischemic stroke. And it's just such a slog and so difficult as a single investigator or institution to push your own medication outside of pharma. And, you know, he's been dogged about doing it, but it does seem that we don't have mechanisms nationally to really try out medications like that unless you're a pharmaceutical company. Do either one of you want to comment on that? Wayne, what about you?
Yeah, I think absolutely. And it's not, you know, it's not an easy time to do translational studies. Sometimes very difficult to find a right.
So Wayne, in the slide you showed, there were 8 institutions. Are those 8 institutions doing their own drug, or are many institutions involved in each one?
Actually, in order to be select for the span, and each center have to show they have a promising molecule want to test. Part of the work is actually they all have to replicate it, the effect within the network.
And now I understand NIH will do the replication in the animal models, right? They have a lab there that replicates stuff.
Actually, all those 8 centers, they have labs. They also select
that's the
those lab.
replication mechanism.
Yeah, they also select a lab with a different level of animals. Some are small animals, some of them non-human primate. Until they want to kind of further select those 7 molecules before they moving towards the translation process. I mean, they will move
those
from
7 molecules will be tested in multi-center trials.
Yes.
Okay.
Yeah. And before they move on to StrokeNet to test their neuroprotective effect in during the endovascular and procedures. With this, StrokeNet also now call for proposal, actually called a Stepstone, which is a very large platform for endovascular therapy. So the idea is they create a platform and you can introduce different device and molecule to push the stroke therapy.
And NIH pays for the trial?
Yeah, for the StrokeNet, NIH invested almost $60 million infrastructure and money every 5 years.
Wayne, why doesn't pharma buy into that as well? Like pay for like half of it, and that they would get some right to the drug if it worked?
There is a stair process, but the problem is the stroke translation success rate is so low. A lot of pharma kind of give up in the process because the return is just so low.
Yeah, for the young folks who don't know, 20 years ago, glutamate receptor antagonists were doing the exact same thing, and they just turned into a giant bust. And I think pharma gave up at that point. Do you think that's the explanation?
I think this likely explain a lot of stuff. There is called a STAIR, basically the academic and industry roundtable stroke therapy. It's been gone for probably 10 years, but pharma doesn't seem to invest a lot of money through the process. You know, if you look at a break, you know, thrombolytic and endovascular, and you know, these only 2 and the success we have in the last 20 years. So, which is not bad. You know, at least we are making progress.
Yeah,
You know,
I mean, I agree, but we don't have any other questions, I think, because of the time. But I'll keep talking. You know, they've invested so much on the front end, like this, But I think, as you know, Wayne, I think some real breakthroughs will come on the back end through therapy after stroke, rather than all this money invested in trying to make the stroke smaller.
Yeah, I think the NIH Blueprint is another initiative by NIH really to push some of the small molecules for neurotherapeutic, including a stroke. So that's why Dr. Sandler, we kind of resume the conversation again, and he has molecule done all the preclinical work and with G-SNO reductase inhibitors, we think it's a time to ready to start first the human study. What I see this is is also have a neural repair and effect. So, but translation process is not easy. Yeah, and then once go to human study, it's just very, very expensive.
Very messy.
So,
all right. So,
Rich,
oh yeah,
Kevin,
go ahead.
Can I add something from the pharma side? I mean, big pharma has stripped down their R&D completely. You can look at GSK; they've gotten out of neurology almost 100%. So all the funds that were spent in the 90s and early 2000s, as Dr. Feng mentioned, were fruitless. I was involved in a couple stroke trials. So what has happened is pharma's looked at R&D and said, that's a waste of our money, we're not going to spend it there. But they may be willing to start shifting back to small investigations that may be fruitful. And for Danny, I would encourage him to keep working at it. Hopefully the government
you can't stop, Danny, so no need to worry about that.
So that, because what they're looking for now is investigators in smaller groups, other biotech companies, to come up, at least to get it up through the preclinical work that needs to be done, the initial, like Danny's doing, the pharmacology to go ahead and demonstrate that it is safe and we understand metabolism, and then to get it in, you're going to probably need a successful phase 2 study. So you're going to need a small clinical trial to document efficacy with measures that the agency, I mean, this is all work pharma used to do, that the agency will accept as an acceptable endpoint. And that's often the difficulty, because a lot of these things clinically have never been established. So it's, just keep at it. Hopefully pharma will wake up and say, yeah, we'll get back into R&D again.
Yeah, and the other thing, Kevin, if you could comment, is the role of the institution. Like, should Duke or MUSC put money behind this? My feeling is they would view that as a huge risk and not do it.
Yeah, and that's the problem across the board with R&D. It just, a lot of it is shifted over to venture capital, and that's what you have to generate the funds to be able to get the early work done, to get pharma interested enough to outlay the funds to either purchase it outright or co-develop it.
I always like to say the difference between pharma and academics is, in academics, investigators are invested in either making their drug succeed or making it look like it succeeds, whereas pharma, they are so invested in making sure it actually succeeds. They can't afford to spend money on something that really isn't going to work.
So Rich, it's Carmen. I have a question and a comment.
Sure.
I thought it was very interesting, really nice talk. I got interested in nitric oxide about 8 years ago because a good friend and colleague of mine here at Duke actually has been working with nitric oxide, looking at as a red blood cell protective strategy. So it's a slightly different mechanism. And there were 2 companies back then that produced inhaled nitric oxide, because that was another approach that we looked at, whether we could use inhaled nitric oxide as a nitric transfer and use that in the post thrombectomy study. So we actually went all the way through towards having Mallinckrodt, which is the company that made the nitric oxide producer. They funded us a pilot study to about $250,000. And we literally got a month or 2 away from IRB submission, and suddenly they pulled the $250,000 as quick as they gave it. and decided to go down the road of cardiac arrest nitric oxide as a brain protective strategy. So, and again, I don't know where that went, but just to share that there, instead of pharmaceuticals, there's a couple of companies that actually make the inhaled version. There's also another one that our anesthesiologists here at Duke have been working with, where they don't have to use a gas that's produced in a laboratory, but they can actually create the nitric oxide gas at point of care. So they have a device that actually creates and concentrates it as an inhaled option. And you know, you may want to also look at some of that mechanism, given that there are companies producing these gases that are interested. The last that I heard, they wanted to put it in an ambulance and do it as a pre-hospital treatment, where you would have a nitric oxide concentrator in the EMS and do it similar to what they did with magnesium. And Wayne, you're familiar with this, you know, that there was a nitric oxide study, which was, I thought was horrible. And that was using nitroglycerin paste in the ambulance as an
Yes.
NO transferring agent.
Yeah.
And of course, NO paste makes you hypotensive, which kills all the benefits of giving a nitric protector if you make the patient hypotensive. So I think in the stroke world and in the cardiac arrest ischemic world, there's still interest, maybe not as a drug, but as an inhaled. And I was wondering what you think of the inhaled NO as an option to achieve the same thing you're describing.
I think inhaled nitric oxide all depends on the environment and the disease condition, disease state. It can react with superoxide to make epoxynitrite. That is the drawbacks of that. And that's being even now tested as a inhibitor of COVID-19 infection, because the compound which I described, one of them, SNAP, was described to block SARS-CoV-2 infection earlier. But when under disease conditions, giving a gas is not will be clear outcome in that case. That's my opinion.
One of the hypotheses was that because nitric oxide is also a microvascular vasodilator that only works under acidotic conditions, that in a way you could use inhaled nitric oxide to vasodilate only ischemic tissue. And if you only did it in the first 24 hours before you started forming the free radicals, that it would provide both vasodilation and some neuroprotection. And you're right, the question was, we had no idea exactly how long to give it before it started potentially producing the free radical species.
So Carmen, that's a good point. And, you know, I talked to Fernando while he was here. I think part of, you know, if you introduce exogenous Gs now, it have to be caster-based, you know, really infused to local ischemia tissue to avoid a systematic vasodilator effect. You know, or I would say, you know, a lot of those studies basically just systematic IV. The dose, my view is we don't know is actually a good dose or not. But if you increase the dose, the next thing is they drop the blood pressure. So introduce exogenous and G-node clear has some drawback. Maybe we need to think about the combination. Introduce some level exogenous G-node, increase nitric oxide without actually systematic vasodilator effect. At the same time, you also give you find a way to boost the endogenous kind of nitric oxide, maybe as a way to and maybe it might be viable in a solution. So I don't know, but need to be tested, you know, in a human study first, look at safety and a dose first.
Well, Dr. Singh, thank you so much. A great talk and a great discussion, everybody. And Wayne, thank you for your insights and for setting this up. And everyone have a great and safe day.
Okay, thank you. Thanks, Dr. Singh. Yeah.
Thank you so much.
Okay. Okay.
Bye-bye.
Okay. Bye-bye.
Bye-bye.